Hey, my name is Will, and I'll be here today teaching about antibiotic stewardship. I go to the Mississippi University for Women. Today we'll be talking about what is antibiotic stewardship, contributing factors to creating multi-resistant organisms, how is MDRO treated, how is MDR spread, and risks associated with taking antibiotics when not needed, and how to acquire MDRO, and then antibiotic prescription monitoring. Antibiotic stewardship. Antibiotic stewardship is a coordinating program that promotes the appropriate use of antimicrobials. This improves patient outcome, reduces antibiotic-resistant organisms, and decreases the spread of infectious multi-drug resistant organisms. Multi-drug resistant organisms are bacteria that have become resistant or immune to many different types of antibiotics. These antibiotics can no longer be used to control or kill the bacteria. This happens when people are getting antibiotics and taking them only for a short period of time. The bacteria gets immune to that certain type of antibiotic before it can get killed off. Well, now you have this organism that can fight off that type of antibiotic, and it takes stronger ones. And then sometimes we can't kill these bacteria because they become immune to all of our different types of antibiotics. So they're very difficult to treat and very easily spread. If a patient gets sick with MDRO, they stay in the hospital longer and increases their chance of mortality. Examples are methicillin-resistant Staph aureus, MRSA. I see this in the hospital all the time. You know, we check a patient's their wounds or even in their nasal, and it'll come back and they'll have this, and we'll be treating with Zocin and different types of antibiotics, but sometimes it just controls for a little while and we're not be able to kill it all off. This is just a picture explaining the contributing factors and how MDRO is created. Factors contributing to MDRO: widespread use of antibiotics, taking antibiotics when they're not needed, taking antibiotics for long periods of time. Over time, a few bacteria will survive after the course of antibiotics are finished. The more the antibiotic is used, the more likely it is that resistant bacteria will develop. That's what I was just explaining. Taking antibiotics when they're not needed. This is another thing. Here in the Delta, we have a lot of people, and the woman that used to keep my children, she used to say every time when I go pick them up, well, so-and-so, he's been coughing, and he's got this, you need to go get antibiotics. You need to go get antibiotics. So, every time she would just hear a child cough, she wanted them to go get on antibiotics. Well, not every time a child coughs, they need to be on antibiotics. There's a lot of different things. Bronchitis, viral for the most part. You got the croup, which is viral. So you're not going to treat a viral infection with antibiotics. But some people you can't tell this to, and they don't understand. They just think antibiotics is the fix for everything. How is MDRO spread? Most often, MDRO is spread patient-to-patient through hands of healthcare workers that do not wash their hands. I see people all the time that step out of an isolation room, and then all of a sudden something will happen and they'll have to jump into another room and they haven't even washed their hands. We have an infection control nurse that's constantly around the ICU, making sure that we're washing our hands when we come out of the patient's room, always gowning up when we go into isolation rooms like these patients that have MRSA and MDRO and things like that. But sometimes it does happen. Direct contact person to person, such as touching and oozing sore. They can also spread on objects such as IV poles, medication cart handles, bed rails, and TV remotes, just to mention a few. We have, you know, they have what we call terminal cleans whenever we clean the rooms out on these patients that have, you know, have been in isolation, contact droplet, or airborne, whichever one. But when we have in a room, you know, that a patient has a Acinetobacter, we always have to, that's a very terminal clean. And even after the patient, you know, is gone or, you know, transferred somewhere else or anything like that, you know, when housekeeping comes in and cleans, you know, our infection control nurse, she even comes in behind them and tests all these objects that are in the room. And if one of them fails, the whole room gets cleaned all over again. How to treat MDRO. Multi-drug resistant organisms are hard to treat since they are resistant to most antibiotics, even the strong ones. Find the source of the infection and use widespread antibiotics can control MDRO in most patients. In some patients, even though the infection is gone, MDRO can be colonized in the nose or in the skin. You know, like I said, it can be in a nasal, you know, when we test with Q-tips way up there, and you know, sometimes it'll come back positive. But it's like it's controlled environment, but you know, it's still they have this infection. Risk associated with antibiotics. Misuse or overuse has increased the numbers of multi-resistant bacteria. Antibiotics are used to treat bacterial infections, not viral infections. If taking an antibiotic while having a viral infection, the antibiotic is still attacking bacteria in your body, bacteria that are beneficial or at least not causing the infection. So this is what I'm talking about on some of these people that don't understand that, you know, antibiotics aren't the calling for everything. You know, when you have a viral infection, you don't need to take antibiotics. Viral has to run its course. There's nothing that we can do about that. You know, overuse of taking them for long periods of time when you don't have this infection and you're just taking antibiotics. It's, you know, it's harmful for these good bacteria that's in your body, you know, in your gut and all. It can kill off bacteria that our body needs. How not to acquire MDRO. We need to improve our hand hygiene. Make sure we rub our hands vigorously together for 20 seconds or longer and dry well. Always use contact precautions when dealing with a suspected MDRO patient. Education and enhanced environmental cleaning. When we have a patient that comes in from that is a hemodialysis patient, has any kind of port access, is a nursing home patient, has had any kind of multi-drug resistant organism in the past 90 days. There's one more I can't think of right now, but we test them every time we come in. We put them on contact precautions and we test them for MDRO, and we do not take them off of isolation until their MDRO screening is back from the lab. So, you know, we try and, you know, take precautionary reasons on that. Education, we do need to educate the public more about these things. You know, I try and teach people all the time about different, you know, antibiotics and the importance of taking all antibiotics, not just half the bottle and then putting it up and saving it for a later use. That's not how you take antibiotics. You know, you need to take the antibiotics throughout the full course, you know, as the doctors prescribe, and make sure that bacteria is killed off or gone before you stop. Because, like I said, when you do stop and the bacteria is still alive, the bacteria is building an immune system to this antibiotic, and that antibiotic will no longer work, and that's how we create these multi-drug resistant organisms. Antibiotic prescription monitoring. The Center of Disease Control and Prevention monitors and evaluates the way the antibiotics are prescribed. The results are used by clinicians and healthcare systems to determine if antibiotic prescribing patterns meet appropriate standards. You know, I think this is a good thing because not all these doctors need to just be writing, and they know, but they, you know, not need to be writing antibiotics just to make the patient happy. You know, sometimes the patient has to learn for their own, and we have to teach them that this is not the right way to treat an infection, you know, or a viral disease that, you know, we can't do anything about with antibiotics, but, you know, they'll just have to get. At least 30% of antibiotics prescribed in an outpatient setting are unnecessary, meaning that no antibiotics are needed at all. This is what I mean. Overprescribing these medications can help form these superbugs that are resistant to many antibiotics and make hard to kill. 30% of antibiotics prescribed in an outpatient setting are unnecessary, meaning no antibiotics were needed at all. 30%. So, you know, we're prescribing these antibiotics to things that, you know, are not treatable by antibiotics. And here's my references that I use to obtain all the information I got from this slide. I hope this presentation, you know, helps people understand more about why antibiotics are used. You know, they're used for bacterial infections only. You know, they don't kill viral. So, you know, it just helps the public know more about why antibiotics are prescribed, and, you know, maybe it'll help this number, 30% of all, you know, antibiotics that are prescribed didn't need to be. Maybe it'll help that number and educate some of these people that don't really know. So that's the only way that this is going to help, you know, is education, you know, making sure we use contact precautions or any kind of precautions that you know, bacteria is, you know, and making sure that we keep a clean environment. Make sure we wash our hands. Every time I go in a patient's room, I wash my hands. If I don't sit down and scrub for 30, 45 seconds, I at least use our little hand sanitizer, you know, every time, especially even when we're busy. I'm always doing that. I always wear gloves. I don't want any kind of bodily fluid or blood or anything like that getting on me. So I always use safe precautions and trying to decrease the risk of transferring these multi-drug resistant organisms. And you know, it helps our patients, you know, not being in the hospital as long. They don't need to acquire these organisms. And, you know, a lot of places, they call them healthcare associated infections, but, you know, if they come in the hospital without MRSAs, just say, for example, and then they end up on the vent, and then they've got MRSA in their sputum, you know, how did they acquire that? We somehow acquired that. We might have introduced it to them whenever we tubed them, you know. It just, so, and, you know, their insurance is not going to pay for that. That's on us. All those antibiotics is on the hospital. You know, so we have to decrease the risk of transferring these infections to, you know, different patients. It's different when these patients come in with it, but, you know, we can just try our best and hopefully not give it to another patient that doesn't have it. Sometimes I'll be at work and I'll see 5 isolation carts, you know, all beside each other, and, you know, I'm like, well, did they come in like this, or did we, you know, have it's gone down the line and just giving it to these patients? But, you know, it's not like that, because I'll check into it further, and some of them might have the flu, and this one has enterococcus, or, you know, and this one has MRSA. So it's not that we've been giving it, and I can promise you our infection control nurse would be on us for sure if we did anything like that. No doubt. She is a one of a kind, you know, she stays on top of us. She even has, you know, people that work for her that we don't even know about that come in and out looking at us and seeing while we're working. And so you always have to be careful, and you know, it's good to have people like that to make sure you're doing your job and making sure that you're not trying to give these patients, you know, MDRO or even, you know, anything like that. All right, well, thanks for listening, and hope this helps out.